Welcome, audience, to a series of podcasts around the IMED conference, which is coming very soon to us in November. We're very excited to be welcoming with us Dr Nathan Pinskier, who is, of course, incredibly well-versed and well-knowledged, not only in the AI space, but when it comes to regulation and it comes to data sharing. He's going to be telling us all about his experiences in the space. Welcome so much to the program, Dr Pinskier.
Hi, Alexia. Great to be here.
Now, we were just chatting before we started all about, the movement of IMED in general in Australia. What's your feeling on the Australian healthcare landscape? Where do we sit when it comes to AI? Are we behind the rest of the world? Do we need to catch up? Are there elements that we're stronger in with the rest of the world? What's your thinking?
Look, I think Australia is really well placed in terms of its overall health service capability, in terms of its digital capability. In terms of AI, I think that's an emerging space. There are some fields where AI is starting to move to the forefront. Broadly, though, across the whole of the health continuum, it's not widely used.
And is that because of the patient journey not requiring it as such, or is it because we're just not utilising the technology that exists in the rest of the world, in your opinion?
I think it's probably a combination of both. It's partially related to the way that healthcare providers are trained. You're trained to be able to think independently. You're trained to be able to make decisions essentially on your own. Sometimes it's a bit embarrassing to have to refer to other devices. The role of computers has not been fully embedded within clinical practice. It works at a level, but in terms of the decision support, which is really critical, and that's where AI plays an important role, we haven't yet, from an algorithmic perspective, locked down standardised decision support, which effectively means that if you have different software products, they can provide different advice, and that can be clinically unsafe.
And that's something that you're quite passionate about in terms of clinicians being able to roll out a more, stable and more streamlined approach. So you're involved with the General Practice Deputising Association. Can you tell me a little bit about how you work with GPs at all levels to advocate and support them in their digital journey?
Yes, one of my roles as president of the General Practice Deputising Association is to support the RACGP to develop standards for safe medical deputising and care in the out-of-hours or after-hours period. That's been a real challenge in terms of the digital component for after-hours. And you can imagine, Alexia, that if you have a relative who at 2 a.m. Has had a medical problem, maybe short of breath or fallen out of bed or whatever, and one of our doctors comes around to see you, and a locum doctor is a doctor acting for and on behalf of your regular GP, the one thing you'd really want to have is access to the medical record from the GP, and that's proved to be a real challenge in the past. Some of the work that we're trying to develop in conjunction with the College of GPs and with the government is around having access to the doctor's GP. As a proxy, we have access to My Health Record, but again, that's a fairly new program, and it's going to take time before most Australians have sufficient content. So building those alliances and bridges is really, really critical so that you get the right information about the right patient in the right place at the right time so you can make the right decisions.
You mentioned software, and I guess GPs are really on the front line when it comes to patient healthcare, particularly in an emergency or, first responder approach, I guess, when it comes to a healthcare emergency. Those, have we got an issue where different practices are using different software? Is that one of the reasons why they're not talking to one another, and it's about standardising that?
Look, this is a really interesting area. It's really been a evolution over the last 30 years or so, and when I talk to medical students and even my colleagues, I talk about my journey, which, if you're my age, I'm now 62, has been a fairly similar journey for people of my era. When I started, we used 8-inch by 5-inch cards. And I recall the very first practice I worked in as a general practitioner, and these are the same cards that my GP used, by the way, when I was a child. They said, now remember, these cards need to last us approximately a year or two, so don't record too much on these cards. The first patient I saw had a chest infection, and I wrote down URTI, upper respiratory tract infection, URTI. I prescribed an antibiotic, amoxil. I dated and signed it. That took one line. Now, today we're dealing with lots and lots of clinical information. I doubt that I could do that today. I doubt that most doctors would want to do that today. It's not clinically safe. So what we saw over the last 30 years was the evolution of software, the internet, the ability to build different systems. And it was a bit of a mad scramble. And in that scramble, we ended up with lots of different programs using lots of different processes and a lack of standardisation. So the work that is happening now currently is around about how do you standardise those products, not so that they lose their differentiation or their unique selling proposition, but essentially that if you enter information into one product and you require an output, you get the same outcome across those products. It's very much like if you buy a car, you expect the steering wheel to be a steering wheel, the brakes to be brakes, the handbrake to be a handbrake, the traffic lights on the road to look like traffic lights. There's an expectation of what standard or what normal looks like. In healthcare, that's not the case, and you get variable outcomes. And people like Enrico Carrera have reported on this, and this is a real challenge. In the messaging space, for example, which is also a significant challenge, we've built, or vendors have built a number of different secure messaging products. Now, if you think in the ordinary world, if you want to send an email to someone, you get their email address, you record some information, you add an attachment, whatever, or a photo, you send it. High level of confidence, it will end up with a recipient. In the secure messaging space, it's a bit like the old rail gauge problem with the train system, or like the telephone system not communicating. So Telstra not talking to Optus or not talking to Vodafone. We have a number of different vendors who historically have not shared the gauge between each other, not interconnected. So the work that I'm doing in conjunction with the Australian Digital Health Agency is to connect those gauges. And then we can start sending secure messages between healthcare providers, encrypted, where only the intended recipient can open the message. So the world that we're moving into is one of being able to share information securely and confidently, and that requires standardised product, whether it's at the desktop level or whether it's at the communications level.
It's an interesting prospect you were mentioning there about the different forms of communication, because we are so used to sharing content between one another in a business sense, in a personal sense, but there is that added issue where you've got privacy and the regulation. How are the regulators, because you talk to regulators as well when it comes to privacy of information and trying to keep these communications open while still maintaining privacy for the end user. How do you navigate that road between what regulators want to do and the sharing of information?
Again, it's a really interesting area, and in the conversations we had in the years leading up to the evolution of My Health Record, this came up in multiple community conversations. So at one level, some consumers expect that information that they've provided to their hospital or provided to their GP is available to another healthcare provider when they wander in. They don't want to keep telling their story over and over again. And at the other extreme, you've got people saying, well, I only want that information to be shared if I consent to do it. It has to be controlled by me. So you get into this really complex area of how do you provide access to information to the right healthcare provider when it's required. And we've built secure messaging products to try and ensure that there are appropriate channels so that information is kept secure and private and confidential. Yet I know quite often people default to the lowest common and easiest pathway when there's a crisis. So if a hospital rings up and says, Nathan, I need information about this patient straight away, quite often you'll fax it through or you'll tell them over the phone. You probably don't go through a proper identification process. It may not even be that hospital. You don't know. So we run into these problems where it's urgent. We take the path of least resistance. And for most routine stuff, normal day-to-day stuff, we try and do it securely. We want to be able to do it securely all the time, every time.
And I guess that's where neatly comes around to the movement like IMED, which brings clinicians and patients as well as the IT providers in the same space. Is it a matter of the IT providers, as you mentioned at the beginning, running down a pathway that is trying to solve a particular problem but doesn't help with the communication issues? Is it important that they become part of the conversation from this point forward?
Yeah, look, in the work that I've been doing over the last 20 years or so, I've had this fantastic opportunity to work with and intersect with people from, whether it's, as you mentioned, from government, whether it's regulators, healthcare providers, peak organisations, consumers, technicians, architects and others. It's been an amazing amalgam of individuals who have helped build various products. One of the challenges is, however, people tend to look at it from their own perspective, with their own focus. So if you're a clinician, you look at it from a clinician view, consumer looks at it from a consumer view, and technicians tend to look at it from a technical view. They see a problem and they think, oh, I've got a software product, or I've got an idea, or I can create a solution. And quite often their solution is not the problem that I have as a provider. So you end up with a piece of technology or a piece of software that is interesting but has no practical application. So the challenge is, how do you co-design? How do you work together, collaborate, co-pilot to build product that actually has a purpose? And the challenge for the AI movement will be to define a space where it actually value adds for clinical services. And we're already seeing that happening in radiology and pathology, where AI is making huge leaps forwards. And some of my radiology friends are worried that they'll be out of a routine job in 10 years' time. And that might be true. It might be that if a machine can actually make a diagnosis much more accurately and much more reliably, irrespective of time, irrespective of how tired you feel, then why wouldn't you use the machine? ECG machines can already give you really high-level diagnoses. We're already, as I said, seeing that pathology, and we're seeing that in radiology. And my friends are saying that sometimes the machine is saying, I can't quite make the diagnosis, but I think there's something abnormal. You need to look at a few more slices. And my friends are saying when they go to those extra slices, they find something abnormal. So the machines are starting to provide predictive analytics as well, which is something a human can't always do. So that's the great opportunity. And then for the radiologists, the question is, well, what are they going to do in 10 years' time for the machines are doing all the routine reports? Well, maybe they'll move into an interventional space because AI can't actually do the hands-on stuff. And I guess the same question then becomes for general practice. If machines are starting to do some of that routine analytical work, where does general practice fit? I don't have any great concerns because I think this is all an enabler. It's going to support the way we deliver healthcare. If the machine can provide us with information that I can't readily remember, because there may be 100 causes of things, I can remember the top 5, but the next 95 I'm going to struggle with. The machine can prompt me and guide me in the same way that the Star Trek computer provides guidance and advice. Well, I think that's fantastic. And at the end of the day, healthcare is a person-service industry. It's about relationships, and it's about the feeling and the contact, that feel-good factor you have when you see a particular provider. Machine can never replace that. So I see a fantastic future with AI. It's a question of, though, how we work collaboratively to create that solution.
I love the way you were using the word enablement, because it's almost freeing up the clinicians to be able to do more complex or more humanised decision-making or contact, because I don't think we'll ever live in a world where, you go and you get your diagnosis, you lie down and table and it tells you what's wrong. That's not going to help you make decisions about your healthcare from then forward. So talking about the education space, because you obviously work within the GP Association to assist with education and CPD, is there a change afoot when it comes to the education for GPs? Is it moving more to a better understanding of how AI can improve efficiencies? Is that trickling into the education space?
Slowly. Look, we're on a journey. So the Royal Australian College of GPs is the largest medical professional body in the country, with 40,000 members, working towards a career in general practice. So it's a huge body. It sets the standards for general practice education and training, both pre-fellowship and post-fellowship, and continuing professional development. It's a really crowded space. You probably hear this all the time on the news, that a GP didn't do this right, a GP didn't do that right. GPs ought to do this, they ought to do that, they ought to do something else. They need to know about mental health, they need to know about childcare, they need to know about diabetes, they need to know about mental health. It becomes really complex. So trying to fit digital health into that curriculum is challenging. And some people say, well, we don't talk about e-banking anymore. We just bank on different platforms. It doesn't matter whether I use an iPad or an Android device, or rarely go down to the bank, which is really rare these days. And so there's a view that this should be just embedded into the curriculum. Others have a view saying, well, this is actually different, and you need to have an awareness, and you need to have an understanding of computerization, electronic health, digital health, the decision support, artificial intelligence. So we're actually having that conversation at the moment. I believe I'm sort of in that latter camp where I think we do need to provide more guidance, and that's what our committee, the Expert Committee for eHealth, does. We provide guidance, resources, materials. If there is a demand from our members, we'll develop specific materials. If there's a particular program that's being developed for professional development, or a government program, we'll develop the resources as well. We run an annual survey of our members, so we tap our members, we ask them, what are you thinking, what's current, what are the big issues, And if there's a requirement, we'll develop it. So social media has been a particular hot topic over the last few years. So we developed the social media guide. Cybersecurity, really hot topic. So we developed the cybersecurity guide. So AI, we're not quite there. Apps are another area where we're starting to develop guidance and resource around apps, because there's hundreds of thousands of apps and lots of healthcare apps, and most of them are dubious in terms of their value proposition.
It's interesting that you provide that guidance. I'm wondering, are you finding that in those surveys that the GPs are asking for that information as a continuing practicing education module, or do you think it's more important that it's delivered at university at the beginning, or is it a pathway that needs to go across all sectors?
Look, it's a great question. My daughter's today actually finishing a final exam for medicine in Western Australia.
Congratulations.
So hopefully,
fingers crossed.
all things being equal, she'll be a resident next year. And I've spoken to her about what do you do in terms of digital health, and my view is that it's fairly minimal or relatively non-existent.
What are they learning? That's I guess that's what's interesting for as a consumer. What is it that they're being taught at university to take us into the next century?
It's really interesting what's changed from my perception as a close observer, but not an active participant. When I went through medical school, it was very much an anatomical model. We were starting to move into that social awareness, so that it was a medical model of health. I think increasingly what's happened is the medical students of today are now moving into that social paradigm of health around the team-based care, around the patient-centric care. There's a lot to learn, and when they come out, it's really the start of another journey. The digital component, again, I think is poorly taught, variably taught, and I think there's a lot more work that needs to be done in that space. How can we use machines as enablers? And then when they get into the hospital space, again, the software is so variable. They find quite often that when they're looking up advice for information, they go to Dr. Google. And whilst we always say, do not confuse my medical degree with your Google search, inevitably, Google does provide a lot of information. Now, clinician can normally decipher that. Educated consumers probably can as well, but it's a challenge to get it right. So we've got doctors running around hospital using their iPads and iPhones, taking photos on iPads and iPhones, because the clinical software does not meet the requirements going forwards.
Well, I can see why you'd be so passionate about that, because I'm just thinking of it from a logistical point of view. Multiple devices, multiple streams of information and data across platforms. That's, I guess, why you're so passionate about channeling it into a singular route so that the patient journey is just following the same path from beginning, middle and end.
Absolutely. So we've got to fix some of those core foundation problems. And I have a relative who works in a hospital in Melbourne who was over on the weekend, and she's second year out, and I was talking to her about her systems, and she was saying they are unsafe. They're inherently unsafe. She says some information gets entered into System A, some information entered into System B. Unless you know System A has the information, when you're talking to the patient, you don't pick up the care plan, the current medicines, because it's in a different system. That's a problem. So we have to fix some of these interconnectivity, interoperability issues before we can start to tackle that big issue around AI. And the big movement that's occurred, and I think this is a really exciting story, is the development of FHIR, which is Fast Health Interoperability Resources. So Fast Health Interoperability Resources is a new set of standards which were first envisioned by a Melbourne health architect by the name of Graham Grieve. And Graham has become a legend now in the international community. FHIR has been adopted throughout the US, through many parts of Europe. It's now a standard for Apple and for Microsoft and for Google, and they're using it now to extract information out of systems and create a common view. So FHIR will rapidly solve many of the problems we've been dealing with around interconnectivity and interoperability. And what it does essentially is works at an atomic level or a word level, so that the meaning of a myocardial infarction or a heart attack is consistent across different products. And it's structured and coded against the standard called SNOMED. So once you've got all that structure in place, you can start to aggregate data, and then you can do the artificial intelligence decision support, because the machine understands what it is you're talking about.
It just sounds as like it's a translator. It's a universal translator to aggregate the information into a single funnel. So we've got all the information that's being spoken about in lots of different ways, but it's actually just in a practical sense, we just need it to mean this, and that's moving forward what it's going to mean.
Absolutely, because consumers or humans can understand at a human level. If you read a report, you can understand it because that's human language, but a machine may not understand what you've meant by heart attack, myocardial infarction, transient ischemic attack, whatever. There are different terms that sometimes have similar meanings that we use, but a machine won't understand that. So we need to code those back, and we need a way of extracting them so we can move them between systems.
What's stopping a system like FHIR being just completely implemented and rolled out? Is this a regulation issue? Is it the various associations having to come on board and be in one room? Is it going to be solved at IMED?
It's a great question. There is a FHIR workshop coming up next week. No doubt it will come, and next year, sorry. No doubt it will come up at IMED as well. Part of it is around a reluctance historically of software vendors to share their information or to make it easier to share the clinical content within a record. In America, that's now been dealt with through legislation. So there's a data blocking legislation, and software providers and hospitals and other vendors and other healthcare providers have had to open up their information.
I was going to say, is this like an open API issue? Because that's
essentially
happening in other industries.
Absolutely.
It had to be enforced in the US.
Absolutely. So you can think of FHIR as a medicalised way of developing application program interfaces. And one of the projects I'm currently working on is a project funded by the Department of Health federally, developed through the CSIRO, where we're working with a large number of software vendors to be able to send an electronic record summary between general practices. You might call that GP to GP, or provider to provider, or practice to practice. It exists in the UK. It exists in New Zealand. Hasn't existed in Australia. And what typically happens is about 20% of Australians change their general practitioner every year. They go from one practice, they might be living in Sydney, next year they're living in Melbourne, you move, and how do I get access to that information if you come to my practice? Well, if I'm lucky, maybe that practice is using the same software product, and maybe they'll ship it down on a USB stick, and maybe. But what tends to happen is it's printed out, 30, 50, 100 pages get printed out, they may be given to you or sent down to me, and we have to scan them in. And all that rich semantic data gets converted to PDFs and lost. So we're building a FHIR-based application program interface that connects to all the software products where the meaning is consistent, where we can send a summary from one practice directly to another electronically using secure messaging. It starts to bring a whole lot of things together. Then you can build in decision support. So once you've got that information, you can query and ask questions, or the system will prompt you saying this patient needs a vaccine, or this patient hasn't had, or these two medicines might be interfering with each other. It becomes a lot more powerful and consistent.
I'm going to ask you a layman question now, because I'm getting very excited hearing about all this technology and how it can enable not only for a paper-free society, but also thinking about all those records that are going to be maintained and held on to, even far beyond our own lives, and how that medical work can assist with future generations as well. That's really exciting stuff. How far away, if all things are aligned and the stars align and the planets are all aligned, how long would this take to roll out some sort of a measure like FHIR across the board?
Well, it's starting to happen in the US already. So a patient can be, or a consumer can be attending two different hospitals. They can download an app and they can extract information on that app and create a common view of all their medicines. So we're starting to see that happen. One of the other projects that's rolled out in the States, and I think the States is an unusual place. I think we need to accept that, but they do some things really well because of the cost of providing healthcare. So one of the other programs that's being implemented is Open Notes. It's being pioneered through Boston Open Notes, particularly in Beth in Israel. And it's a system where, as a consumer, you get to see exactly what's in the record at the hospital level. So whatever in that hospital network,
I think I've heard of this one, yeah.
You can get to see what's there. And initially it caused the doctors a lot of concern because they're my records, my notes. Mm-hmm. But increasingly I think we're moving, and that's part of the education and awareness, to explain to doctors, in fact, you are the custodian of those notes, but they're actually not your notes, they're the consumer's notes, and they have an unfettered right to be able to access those notes. So we are starting to see this opening up. In Australia, we need to, I think, change some legislation, particularly around data sharing, or to prohibit data blocking.
Or whose data it belongs to.
Whose data is it anyway? Mm. And it may not matter whose it is, but it's a question of who has access to it. Mm. And as a consumer, myself as a consumer, I want access to my own information irrespective of where it's stored. So once that happens, we'll start to see information moving around, and then you can start to build some smarts on top of that. AI becomes really important because it can provide you guidance to say, well, your next doctor's appointment should be in 2 weeks. You don't appear to have taken this medicine. Your blood results have come in. They appear to be they are out of range, whatever. You need to see your GP or have it followed up. That's the potential opportunity.
We can only hope.
Absolutely.
Well, it segues quite nicely into, the purpose of IMED as a movement. It sounds to me like all those pieces of the puzzle that you're describing, the software, the information, the data sharing, the regulation around privacy, those are all pieces of the puzzle that are probably going to be covered and discussed in a very open forum that is IMED. In your mind, why is it important that clinicians and patients or people who are involved in the healthcare sector come along to this conference and learn more?
It's really important because you need to be part of the journey. And whilst you may have a view or not have a view, you need to understand what's happening around you. And going to conferences is a great way of meeting people, whether it's actually in the conference itself or whether it's in the corridors, and you share and exchange ideas. And inevitably, I come out of conferences a lot richer because there's so many things I realise I've never heard about or know very little about that you wonder how you missed it. But the world is moving so quickly. So going to the conference, listening to the keynote speakers, hearing the experiences, talking to people in the corridors over coffee gives you that opportunity to start to think about, well, what would a potential future look like?
Well, I think the healthcare world is all the more richer for having you in it, Dr Nathan Pinskier. Thank you so much for joining me.
Thank you,
My
Alexi.
name is Alexi Boyd from Small Biz Matters. We've been talking to another fantastic clinician on the IMED series. If you haven't already, make sure you go to the IMED Summit information page. There is a summit in November being held. Make sure you register. It's a fantastic opportunity to have AI clinicians and patients and possibly even regulators all in the room to discuss the future of healthcare. Thank you very much for joining us on the program, Nathan.
Thanks, Lexi.